Okay, good afternoon. We will present our clinical case, and my team is made up of Bryan Zaragoza Lopez and his servant Bryan Nicasio Wences. Okay, introduce the patient. We get a 71-year-old male patient with a weight of 18.3 kilograms who enters the neurology service of hospital 270 referred from the clinic for presenting a call of 10 days of evolution accompanied by oliguria and without bladder balloon. Personal and family history and probably COPD, no reports or respiratory functional tests available. Um, that diabetes, mother breast cancer, probable and COPD, and transrenal resection of the prostate for Beijing hyperplasia in 202 and hydrocele is for 40 years age and he is married, lives with high Wi-Fi and has 3 children with whom he has good relations. He has been treated since the age of 16, 5, and since he become very accustomed to his recurrent situation. And next. Okay, and introduce the patient, prednisone and glucose postdamidi, physical examination, conscious and oriented, normal eyesight and colored normal, PA 130 and 18. Frequencies cardiac 18.4, TA and 36, a no edema, abdomen sub and depressible, no pain or palpation, and no bladder balloon sinks. And studies and etiology study was carried out and wishing a high number of anti-MPGJ antibodies and macroscopy hematuria, leukorrhea, and pleururia were evident. And etiology study is watch a number of anti-MG. Final diagnosis acute renal failure. Annette. Okay, and clinical course and diagnostic methods, abdominal ultrasound, magnetic resonance orographic, and renal biopsy. Patient measurements, bladder carotation, it's internet treatment with serum therapy and fluoromicidi during administration, a renal biopsy and performed. His dishes giving is good general condition and good tolerance to treatment and must continue and is program. Next. Okay, low medical treatment open research and Shaisana Chuan and Musipurin to apply um, 24 hours and prednisone 70 mg and 24 is the seeding regimen until total suppression and glucosamide and 124 hours in the seeding regimen until total suspensions according to medical orders and different diagnoses, hemorrhages, peritonitis, coronary heart disease, pulmonary thrombocytopenia, and septemia and Guts-Pasteur syndrome. Next. Okay, and discussion. discussion, introducing the topic. Definition is the definition as the decrease is the inability of the kidneys to eliminate nitrogenous waste products, establishing and oxidases by contradiction of serum and creatinine elevation. Bibliography is Harrison and Medicine's intern. Next. Okay, in epidemiology, mm, 70% of prenatal causes and um, 72 obstructive causes are more frequent in people over 16 years of age, and diabetic people can generally insufficiency at any stage of the disease. There is a 15% mortality. Next. Okay, and geographic and mortality is patient under 15 years of age in Mexico and 31 the 10 14 years um the 5th and 19 is 18 and years and 32 and 1 years and 70 is 1 and 4 years. In most present cases in Latin America and Mexico, um, 14%. Next. Okay, in Mexico, 25%, and mortality in patients with acute kidney injury in Latin America. Next. And etiology, risks and factors, kidney disease, liver disease, diabetes, especially if it's in no controlled hypertension of heart failure and morbid obesity. And causes acute tubular necrosis, Goldbuster syndrome, Seri and Sunday dehydration, toxic kidney damage from poison or center medication, autoimmune kidney diseases such acute nephropathy syndrome and interstitial nephritis, and obstructions of the urinary tract. Next.
Okay, so now I'm going to present the pathophysiology. So in this case, we're talking about acute renal failure, but the etiology from the case we just talked about, it was caused by the good pasture syndrome, which is an autoimmune disease that affects the lungs and the kidneys as well. So the mechanisms of how this occurs, it starts with an anti-glomerular basement membrane antibodies, which it's some antibodies that are gonna attack, like the name implies, the glomeruli, thus causing a nephritis. I mean. So the antibodies are gonna attach to the antibodies are gonna attach to the antigen, and then it's gonna start an inflammation effect, which is gonna destroy the glomeruli membrane, causing vasculitis and causing damage to the kidneys, thus preventing the kidneys having a good or a normal function. It's gonna cause hematuria, which means the blood in the urine, and it's also gonna cause inflammation in the lungs due to the fact that the membrane from the cells, from the lungs, it's pretty it resembles the dust from the kidneys. So it's also going to affect the lungs and it's going to cause inflammation and bleeding in the lungs too. Next one, please. So the presentation. So how we're going to see this disease? Okay, what? First, we're going to talk about the subjective effects, which is going to cause difficulty urinating, the shortness of breath, due to the fact that it's affecting the lungs, fatigue, headache, and confusion once it starts affecting even more due to the loss of oxygen or the well, because the patient is not going to be able to breathe correctly because of the edema and the inflammation caused in the lungs. The objective, we're going to see hematuria, coughing, oliguria, hemoptysis, high creatine levels due to the fact that the glomerula is affected. The proteinuria, also because of the membrane that's being destroyed by the antibodies, edema, hypertension, and azotemia. Next one, please. Um, can you go to the next one?
Okay, so diagnosis and management. The way we're going to diagnose this disease is by utilizing urinalysis, so we can see the different proteins inside the urine, blood count, chest radiograph, so we can see the edema or the bleeding, kidneys or lung biopsy, so we can try to identify the antibodies, and serologic testing for the antibodies of the glomerular basement membrane. So how are we going to treat it? We're going to use hemodialysis in case we got an acute renal failure. We're going to use intubation in case the patient can't breathe accordingly. We're going to use plasmapheresis so we can practically eliminate all of the antibodies in the blood from the patient. And then we're going to try to use methylprednisolone and cyclophosphamide so we can we'll pretty much tell or eliminate the antibodies from the blood and preventing them from creating more. The prognosis for the patient is actually pretty good. It has a 80% expectancy of survival after 5 years once it has been treated, and less than 30% need long-term dialysis. Next one, please. Okay, so the conclusions. During the admission, a renal biopsy was performed, the results of which reported the unfavorable and hardly reversible evolution of renal function. Despite the plasmapheresis sessions, after finishing treatment with plasmapheresis, a definitive assessment is made in which the patient is informed of the state of the renal function and of the possibility of the definitive replacement treatment with hemodialysis. He was discharged due to his good general condition and good tolerance to treatment, and he should continue in the hemodialysis program. So that was the end of the case, and we need to touch on some key points. The recurrence is rare on this syndrome, but it can happen. Patients that do not recover from renal function may qualify for renal transplant, and of course, there's got to be an involvement in different um, health practitioners like the nephrologist, the pulmonologist, and the surgeon, and they should be consulted so we can give a better treatment to the patient. And the recurrence after transplant is very rare, but it can still happen. So yeah, I think that'll be it, and thank you.